Hello, my name is Corey Langer. I'm professor of medicine at the Abramson Cancer Center at the University of Pennsylvania in Philadelphia, and it's my privilege to discuss some of the new findings in ALK-positive non-small cell lung cancer. Specifically, I will focus on the important implications of the J-ALEX trial, potential implications of the ALTA trial looking at brigatinib, and then newer agents in this class, including lorlatinib. The J-ALEX trial is a critical phase 3 effort in ALK inhibitor-naive, ALK-positive non-small cell, comparing the standard of practice, crizotinib, to a new third-generation ALK inhibitor specific for ALK and ROS1 called alectinib. This was a Japan-only trial with a 1-to-1 randomization at a somewhat lower dose for alectinib than that used elsewhere in the world, 300 milligrams BID, versus standard crizotinib at 250 milligrams twice daily. Patients were allowed to have had prior chemotherapy exposure, and so critically important in this group of patients, brain metastases were permitted at enrollment. Patients were stratified by clinical stage, previous chemotherapy, and ECOG performance status 2 versus 0-1. It was a relatively small trial, just over 200 patients accrued, with fairly standard demographics for this population. Median age was roughly 60 across the board. The vast majority were either ECOG PS 0 or 1, and as we've come to expect with ALK-positive non-small cell, virtually all had adenocarcinoma. Brain metastases, there was some imbalance, with 28% of those in the crizotinib arm having previously confirmed CNS mets compared to 13.6% in the alectinib arm. Across every therapeutic parameter, alectinib was superior. Progression-free survival was significantly higher. Median PFS was 10.2 months for the control arm, and it was not reached in the alectinib arm with a hazard ratio of 0.34 that dropped even further for those with confirmed CNS metastasis to 0.08. Response rate was significantly higher at 85% for alectinib versus 73% for crizotinib, and this too was confirmed by a blinded committee checking the status of actual responses. There were no major surprises when it came to toxicity. Across the board, crizotinib was actually a bit more toxic with more GI side effects, including nausea, more transaminase increases, more visual disturbance, although generally grade 1 or 2, and more fevers as well as dysgeusia. Of note, 20% of patients in the crizotinib arm stopped treatment because of AEs compared to only 8.7% on the alectinib arm, and there were far fewer dose interruptions for alectinib. So this trial actually closed relatively early. It was the second pre-planned interim analysis for the phase 3, but with such striking advantage for alectinib, at least in Japan, this has now become the standard of practice first line in ALK inhibitor naive ALK-positive non-small cell, and I strongly suspect the same will hold true in North America and perhaps for the rest of the world. Of course, we are awaiting the results of the other ALEX trial, which is a more global effort, again with a very similar randomization. And of course, we are awaiting survival results, although it's unlikely we will see much difference considering the crossover that might occur and the ultimate use in chemotherapy in patients whose disease progresses on these compounds. Another critical trial was the ALTA effort. This was a randomized phase 2 looking at 2 different doses of brigatinib, another ALK inhibitor. Brigatinib in phase 1 and phase 2 had shown remarkable activity in ALK-positive non-small cell with relatively minimal side effects, with one exception. Pneumonitis seemed to be related to dose, and that was generally a very early onset, usually within the first week or 2 of therapy. Like alectinib, this agent, brigatinib AP26113, notable for CNS penetrance that was generally superior to that seen with crizotinib. ALTA was randomized phase 2, evaluating 2 separate doses of brigatinib, a standard dose of 90 milligrams daily, and then a step-up dose starting with 90 milligrams daily for a week, going up to 180 milligrams daily at the end of 1 full week of treatment. Randomization was 1-to-1. Again, these were specifically adults with crizotinib-resistant ALK-positive non-small cell lung cancer, so a different population from the J-ALEX trial. No restriction on the number of prior chemotherapy regimens. Just over 200 patients were randomized, 112 on the lower dose arm, 110 on the higher dose arm. And with respect to demographics, again, a generally younger population. The median age overall was 54, fairly healthy. Only 7% had PS2. And the vast majority, nearly three-quarters, had had prior exposure to chemotherapy. Again, unlike the J-ALEX trial, much higher incidence of brain metastasis, nearly 70% of individuals on either arm having already documented CNS metastases. Response rate was slightly higher in the higher dose arm, 54% compared to 45%, and this included 4% complete responses. And PFS was also somewhat higher, 12.9 months for the step-up arm to 180 milligrams daily compared to 9.2 months. Now, the study was not powered for comparison, but based on these results and at least tolerable toxicity, the plan is to go forward with a phase 3 trial comparing the higher dose arm to standard crizotinib, again in the frontline setting. It should be noted that neither arm was median survival even reached. The one-year survival rate for the low dose arm was 71% compared to 80% for the high dose arm. And we see fairly similar toxicities between both arms, with a 3% incidence of grade 3 or higher pneumonitis overall, necessitating a treatment discontinuation about half of those patients, so about 1.5% stopping treatment because of pneumonitis. So again, another promising compound, the 12.9-month median progression-free survival seen with Brigatinib at the higher dose equals or exceeds that seen with alectinib in the same setting. I suspect both alectinib and Brigatinib will be major agents in the frontline setting in the not-too-distant future in ALK-positive non-small cell lung cancer. Big question, of course, what do we do if individuals have progressive disease on these compounds? Lorlatinib, which was presented during Clinical Science Symposium by B.J. Solomon at ASCO in 2016, may potentially address this issue. Again, another promising ALK inhibitor with major CNS penetrance. Individuals who had been pretreated with one or more approved ALK TKIs were enrolled on this study. This was a phase 1 looking at a number of doses. Bottom line, fairly standard demographics with median age of 52. Again, the vast majority were ALK positive, 76%, but of note, 22% were ROS1 positive. The only major toxicity of note was hypercholesterolemia. Overall response rate in this heavily pretreated population was 50% with those with one prior ALK TKI and 35% for those who had received 2 or more. The capacity of this agent to potentially work in those who have had other second or third generation ALK inhibitors is of note, and it's really quite amazing when we think about it that so many new agents are available in a niche population that constitutes perhaps 4 to 6% of all advanced non-small cell. Thank you for your attention.